We're at the 22nd CROI, and I'm Fred Scheich with IFARA. We're here with Ingrid Bassett, and she is with Massachusetts General Hospital. And you're going to be talking today about TB in the developing world. So there's a lot to be said there because this is a disease that is probably even more prevalent and concerning in some cases than HIV, and maybe along with malaria. So if you would, kind of talk about your experience and maybe why you got into the field and your being at Massachusetts General, but yet working in the developing world.
Sure. Well, I'm trained as an infectious disease physician, and I really have been interested since I was a medical student in global health issues. I think for me, HIV and TB are interesting particularly because they're very interesting at the level of the host and pathogen interaction and how the infections occur and how they stay within the body, but I'm also interested in the broader social ramifications of these diseases, and so I think that's why my heart is really working in South Africa, and I've been working there since 2004.
Mm-hmm. And what is specifically the work that you're doing? Can you describe the kind of work that you do?
Yeah, I work in issues related to linkage to care and optimal ways of diagnosing people with HIV and TB. So really thinking about I think both of these diseases have, they can be diagnosed and they can be treated, but one of the major obstacles is really getting people who are out there who are infected with HIV and or TB diagnosed. A lot of times in the developing world, the way things are structured, that people need to come to the healthcare facility, people tend to do that only when they're really sick. And they may get tested for TB, but it may take time for the TB results to come back. The person may never get started on TB treatment, or they may get started and never finish. So similar to a lot of discussion about the HIV care cascade, where people, they're undiagnosed people, they need to be diagnosed, linked to care, started on treatment, and retained in treatment. I think TB really has those same steps and also has that same attrition at each of those steps. And so I really work on trying to think about how to make the healthcare system function in a way that makes it easier for people to get diagnosed and get onto treatment. And so that may include things like a health system navigator or someone who helps the patient figure out what these steps are, figure out what obstacles or barriers they may have to overcoming those steps, and then how should they proceed. Or it may be how to best use technologies like the Gene Expert for TB diagnosis.
And how do you feel that this is really, I guess the big question is, what is the pathogenesis of this disease? And maybe that plays into why you need to do what you're doing.
Yeah, I think TB, it's very old, and it's been with us for a long time, but in some ways its face has changed a little bit with the HIV epidemic in sub-Saharan Africa. About a third of the world's population has been infected with TB and would have a positive skin test, for example, that shows that they have latent TB, including myself.
But that doesn't mean that they are infectious.
They're not infectious, so their body has been exposed and has contained the infection.
Mm-hmm.
It can, at some later time in life, reactivate or sort of come back to be active again, and that can be precipitated by older age, diabetes, other immune-suppressing illnesses, including HIV.
When your immune system goes down below what, 200 or below 100?
Well, the interesting thing about TB compared to other opportunistic infections is that it can occur at really any CD4 count. So people with lower CD4 counts are more likely to have extrapulmonary TB, meaning TB that's outside of the lungs only. But even people with higher CD4 counts can still be infected with TB. It tends to be more likely confined to the lung, like it might be in someone who has a normally functioning immune system. But TB, it's common among HIV uninfected and infected people. And so one of the challenges is to make sure that both of those groups are getting diagnosed and treated.
And the types of TB are there's some that are quite concerning and are almost unaddressable.
Yeah, well, I think, still The most common types of TB that are diagnosed are what we call drug-sensitive TB, meaning that the armamentarium of drugs that we have at our disposal works against TB. Because of the way TB is a slow-growing organism, it has to be treated for a long time, so at least 6 months. Usually we give 4 drugs for the first 2 months and then 2 drugs for the subsequent 4 months for a full 6 months of treatment. When someone has drug-susceptible TB, then that regimen will usually work. If they get diagnosed, they get onto treatment, and they take it, most cases we'll be able to cure them with that regimen. Where it gets more difficult is with multi-drug resistant TB, or TB that's resistant to rifampin and isoniazid, 2 of our real kind of bulwarks of TB treatment. And when the TB is no longer susceptible to those 2, we end up having to use a lot of second line, or the sort of next level of drugs, which are generally, many of them are very old drugs. They have a lot of toxicities, and people need to be treated for longer. So whereas with susceptible TB, someone could be treated and cured in 6 months' time, with drug-resistant TB, it can be 18 months, it can be 2 years, it can be really difficult to treat. And a lot of the problem comes from the toxicities of the drugs. They're harder to tolerate. They often tend to be, at least some of them have to be injectable drugs, so people need to take them intravenously. So it's both harder to treat and cure because we don't have our best drugs, and it's also harder to treat because, especially in resource-limited settings, it's hard to have the infrastructure needed to treat the drug-resistant TB with injectable drugs. Extremely drug-resistant TB is, by definition, even harder to treat, so resistant to those drugs plus some of the second-line agents. And that has a very high mortality rate, particularly in people with HIV. And it's rare, but it's out there. And one of the concerning things, I think, that was a real wake-up call in South Africa, where I work, was that when there was a documented group of people with extremely drug-resistant TB associated, like in an area of a rural hospital, and there was concern that, unknowingly people were infecting one another within the hospital setting. So that was a difficult situation to uncover, but I think really helpful as a community, because it really made us realize how much we needed to use good infectious precautions against infecting people, and really thinking about, in a resource limited setting, what can you do to try to minimize infection. So for example, having windows open, having UV lights that can kill the TB, having waiting areas that are well ventilated. So even things that are simple like that can help to prevent transmission from one person to another. And I think this also is an important issue as it relates to HIV, because there's a big push to try to integrate HIV and TB care so that it's more streamlined for people to get their treatment in resource-limited settings. But there's concern about the risks associated with that too, because people with HIV who maybe don't have TB but are in the waiting room with a suppressed immune system, could be at high risk of becoming sick unwittingly from other people in the waiting room. So I think this experience with XDR-TB, or extremely drug-resistant TB, in Tugello was a wake-up call about how we needed to really practice good infection control precautions to make sure that we're not doing harm in the healthcare setting.
Is it the strain of disease, or is it also the host that matters?
I would say it's both. I mean, I think drug-susceptible TB, can be deadly, even in people. Can be deadly, particularly in people with a suppressed immune system. And still it's a leading cause of death for people with HIV, even drug-susceptible TB. So there is this interaction between the host not being able to mount a good response and the TB. But definitely, the more drug-resistant it is, and the less able we are to rely on these really good drugs, the harder it is to treat.
Okay. So the work that you're doing, do you do any research as far as in with your setting that you're trying to improve?
Yes.
Because it seems as though is there new drugs that are hopeful? Because it seems like you're treating with the best drugs first. Is that true?
That's right. I think new drugs are slowly coming down the pipeline, and certainly using fluoroquinolone drugs like moxifloxacin is a more well-tolerated drug than some of the older drugs, and we're starting to see more of that. And we're also starting to see another class of drugs, like in the delaminid family of drugs, that are also coming down the pipeline. So I do think drugs that are less toxic and that could have a shorter duration of treatment would make a big difference.
Because the adherence is an issue.
It is an issue. It's a long time, and there are side effects from the drugs, and especially if someone's also being treated for HIV at the same time, there can be overlapping side effects. But I think for me, from a research point of view, I think we're all hoping for better drugs that are better tolerated and for shorter regimens. But I think there are a lot of issues that we could confront now, even with the drugs we have. I mean, TB, it's a curable illness, but we still have a lot of people dying from TB. So I think some of it, the research I'm interested in, it relates to trying to make the system function better so that it's easier for people to get the diagnosis, it's a faster diagnosis, they can get onto treatment and not have it be so burdensome for them to adhere, so that they can be treated well and be cured of TB.
How many people are working in your group? Is there a group that's dispatched, so to speak, or
I work
tethered at great length?
Most of my work is in Durban, South Africa, and I work very closely with colleagues in Durban at the Atemba Labantu Clinic, and I have a project manager, research assistants, nurses who work with me on the research side. One of the things that I'm interested in now is looking at how to use this technology of GeneXpert, which has been a very exciting development in TB diagnostics, because it's a test that can be done within 2 hours to give the person the answer, and it doesn't require a special laboratory, because it's a self-contained reaction that you put the specimen into a cartridge, it goes into a machine, the GeneXpert machine, and processes the sample without creating a lot of aerosol or other things that normally require a specialized lab. So that's been a very exciting development in TB diagnostics. And South Africa actually consumes the most diagnostic cartridges for this GeneXpert test of anywhere in the world. But mainly these GeneXpert machines in sub-Saharan Africa have been deployed in central hospitals or in reference laboratories. And so though the test is a fast one, it still usually translates into results coming back more like in days as opposed to in hours.
It's pretty expensive. The machine is pretty expensive.
It is pretty expensive. But I think because TB is such there's so much morbidity and mortality from TB in developing country settings, even an expensive test is worthwhile, yes. Both from the individual health point of view and also from the public health perspective of treating someone and ensuring they're not infectious to other people. So I think one of the things we're looking at is how best to use this. Can we bring this technology closer to the community, as opposed to having it in the reference lab, and try to take advantage of this rapid turnaround for results.
How important is your education about TB? I mean, helpful would be this.
Yes.
But I think there's some specific things you might want to talk to people that are potentially at risk for
TB.
Yeah.
I think the thing about TB is that unlike HIV, which till now, for now is a chronic illness that requires lifelong treatment, TB, is a curable illness, and I guess. Really trying to stress that it is 6 months of treatment at least, but that you can be cured. And so I think being proactive about being screened for TB is really important, and taking all the opportunities that people can to be screened for TB, especially if they have a suppressed immune system.
Do you have PR campaigns of any sort, or do you not do that kind of thing?
I don't do that as part of my research, but South Africa, the Department of Health, really tries to emphasize to people what the symptoms are. So, to try to help people trigger in their own mind, like maybe I need to seek healthcare for what I'm experiencing. And so typical symptoms would be cough of more than 2 weeks, fever, night sweats, weight loss. Those are the classic symptoms. Unfortunately, not everyone has those symptoms, and it can be much more subtle clinically than that. But definitely, those are the symptoms that should trigger for people a visit to be screened for TB.
I don't want to miss anything in this opportunity with you, but because I know we had encouraged others to participate, but this conference is so busy.
Yeah.
And so hard to schedule. We have the right people here, but they don't come here sometimes.
It's very hard, yes. It's people just want to maximize their time listening to the new science, talking to one another. I mean, there's a lot of discussion.
That's the peer process.
Yeah,
And we talked about virtual conferences at one point, and I think that's good, but I think it's not like the hall talk that goes on here.
Yeah.
Passing and stuff like that people meet their colleagues and then they talk about maybe collaborations and
and what's coming down the pipeline.
How they can be a part of that process as well.
No, I think I think the invitation I got, I didn't really know what it was. Mm-hmm. So, I went to YouTube, I looked and I saw people that I knew had done this before. So I think the way that the invitation comes also is important in terms of people knowing, who you are, where your funding comes from, because I think for me, I also wanted to understand that.
Well, you're young, and a lot of the younger people are not familiar with me because we've been inviting the same people for 30 years. 100 years, I like to say.
100 years. But you have good longevity, 100 years. You look good.
Good for that, right? But the main goal is that we do invite younger people.
Yeah.
And because they're the future of this, the future of the fight.
Yeah.
And we also have to, in the opening lectures, I know were you the young investigators?
I wasn't, no.
Okay, but you've been to those?
I've been there, yes.
So the point to that is really to get you a sense of what we are doing here.
Yeah.
Why we're here.
Yeah.
And Martin Delaney lecture, of course, is always really important to us because he was a champion of our fight, and in so many ways had a very appropriate way to dispatch his sense of activism and his tenor.
Yeah.
But it is important that you get a sense of that, and not you, but everyone.
Yeah.
And so we work together. And AIDS is a little different, and of course TB, because it attaches itself to AIDS in so many ways, is so important because we know that this is something that can be fought with the right attitude.
Yeah.
And so the attitude is very important, and the fight is all about when Yop Long died in that horrible crash.
Yeah.
The news media said the conference may be canceled. I said, oh my God, this is the last thing on the
he would never want that.
No, not only would he, but all of us would say in his honor.
That's right. We go on.
I mean, I don't know what it would have taken to close the conference. Maybe no one showed up. The whole of the planet got frozen down.
Yeah.
But we are really committed people, and I think that whether you be in the TB fight or in the HIV fight or the hepatitis or whatever area or the whole thing, it is important to keep a strong mind.
Definitely.
And an eye on the prize, as Tracy Swan says, and then so many others things.
I mean, I think for me, I am young, it's true, but I've been working in South Africa for 10 years, and even just the difference that time has made. I got there when PEPFAR was just beginning in South Africa, and HIV was such a desperate illness at that time. People, parents would come with their children in wheelchairs. It was very emotionally incredibly wrenching. People, we just couldn't get people onto treatment fast enough. And
so
I think
you began in a different era, but yet a very poignant moment for you.
Yes, it was very exciting to see what could be done with people really focused and with a lot of accountability and transparency. PEPFAR, their bean counters, and that was fantastic because it caused programs to really think about how can we scale up in a way that makes sense and, do right by people. And so it was an incredibly exciting time to be there. And now, I feel fortunate that in some ways we're struggling with some of the same issues in South Africa that we struggle with, in the United States in terms of non-communicable diseases and other complications of HIV. And I think in a way, to be thinking about those things now, I think speaks to the fact that South Africa has, the largest antiretroviral therapy program in the world. So I think a lot has happened in 10 years, but to me, one of the main problems relates to, in some ways, the attitude question or the way we structure our care, because HIV, there's a rapid test that can diagnose it, there's treatment that's very effective, but still in South Africa, it's really still so many people aren't getting treated. And I would say in many ways the same is true of TB. It's a little harder to diagnose maybe, but it's a curable illness. And even as all the new developments happen that we so look forward to, ultimately hopefully an HIV vaccine, better drugs for TB, even the tools we have now, could be very effective if they were really widely available and embraced, and if the system functioned in a way that made it so that people could do right by their health without making too many other sacrifices in terms of missing work and childcare and all the other responsibilities. So, I think in some ways that's the onus is on us as a community to figure out how to.
And the community means the doctors, the community people who are living with the disease, and the people who are in the community, families, friends.
That's right.
And governments.
That's right, and governments, and departments of health. So I think we all need to figure out how to make even the tools we have today, which are very effective as they could be.
We're going to also be speaking with Deborah Burke, so I know that she's going to have an opportunity. And it's funny because we had some of the activists come to me and say, well, ask her how we can help her to move in the right direction or be an assist. Yeah. And it's ironic because the very same moment I heard in the room where she was doing a speech to the community, she said, please tell me how we can work together. So this is a partnership that is obvious. Yes. It's obvious. Yes. But my indoctrination came from the beginning of AIDS. Yours came at a point in time where PEPFAR was launching a push. Yeah. And I just spoke with the gentleman the other day about the Ebola, which is another tragedy unfolding at this moment. Yeah. And in total despair and somewhat disorganized. So I thank you very much for your opportunity to be with us. And
thank you. Thanks for having me.
Look forward to meeting us again
Thank you.
on this platform.
Thank you very much.
Thank you.